fotoğraf çekelim kardeşim. Sen de. Good morning. Welcome to AASLD TASL Hepatology Connect meeting. This is a new one. This session is muscle D session. Muscle D is a more prevalent liver diseases, chronic liver diseases worldwide. I moderate this session with my dear colleagues, with Akyüz. Before further, I would like to say that there was really amazing abstracts and presented by young fellow postdocs, young internal medicine residents. I am very proud of them. Thank you very much for all of them. And the first speaker of this session, Mary Rinella. Everyone knows her very well. She's the muscle D person. She's the right person to talk to muscle D worldwide. And she's from the Chicago University. I was in Chicago at Loyola in 2000. Yes, Mary.
Thank you very much.
Microphone's yours.
Thank you very much. Thank you for the invitation, and it's really a pleasure to be here. It's my first time in Istanbul, so I'm very much looking forward to the next couple of days. So what I'll be doing is presenting to you some of the work that was presented at AASLD in November, as far as updates in the field, and I've thrown in a couple of other things that may be of use. So these are my disclosures. I do consulting for most of the companies in this space, and many of which we'll be talking about today, just so you know that. We're going to start with the first topic, which is non-invasive biomarkers and the prediction of major adverse liver outcomes. This is actually from the paper from which the abstract presented at the AASLD was derived. This is a very nice study led by Vincent Wong and others from Hong Kong, who basically had about 16,000 patients. These data here are coming from about 11,000 patients that had various non-invasive tests. Specifically, we're going to focus just on the Agile 3+, which is basically a calculation based on liver stiffness, ALT, AST, age, platelets, diabetes status, and gender. And so with this non-invasive modality, you can see that the area under the receiver operating curve in the upper right was the highest compared to the other comparative biomarkers. But this study gave us very important insights that I think we really were looking for. So you can see here on the left, there are Agile 3+ score that I just told you about was divided into 3 groups. So the high-risk group, which is in orange, the intermediate group, and the low-risk group. And you can see that with respect to the cumulative incidence of liver-related events, if you have a high Agile 3+ score, you have a much, much higher risk of a liver-related event. In fact, if you're in the low risk group, your hazard ratio is about 0.6, and if you're in the high risk group, it's about 30. So a very significant difference. Other important things from the study were that a change or a reduction in the Agile 3+ score of 20% was associated with a significant reduction in liver-related outcomes. So here we're starting to see how dynamic changes in these biomarkers can correlate with outcomes, and that can be quite effective. Overall, even just a 10% reduction was associated with a reduction in liver-related outcomes and an increase in liver-related outcomes. So I think this is really useful information, and again, I encourage you to read this paper. So this was an interesting study derived from the MESA cohort, which is a multi-ethnic cohort in the United States. And the intention of this study, it was led by Naga Chalasani, was to look at the interaction between those with MASLD, the presence or absence of the PNTLA3 at-risk alleles, and then look at epigenetic and biological age. So the MESA cohort derives these information from about steatosis through CT imaging, so that has some limitations, but they took patients who had a liver-spleen ratio less than 1, who had at least one metabolic risk factor and no significant alcohol or other causes of liver disease. And then they looked at paired methylome circulating DNA in about 885 patients. So you can see that there was an association with these models, even with adjustments that suggested that there was a significant impact of the presence of MASLD with biological age. And if you look over to the right, in the green are all patients, and this is again MASLD versus the epigenetic age based on this circulating DNA, but specifically look at the GG allele, that's the at-risk allele of PNPLA3. And remember, this is a gene that's significantly associated with the presence and progression of liver disease in this context, and also in alcohol-related liver disease. And then an additional study that they looked at using a different DNA sequence or clustering, you can see the same effect. So there's an impact also with biologic age acceleration and MASLD. So again, interesting that, and further evidence that we can risk stratify potentially based on genetic polymorphisms. So moving on to therapies. So all of you are well aware of the GLP-1 as far as a mechanism of action across many metabolic diseases. This is a mechanism that has direct and indirect effects on the liver. There are no receptors in the liver, but the downstream effects of decreased intake, decreased motility have positive impacts on the liver with respect to delivery of fatty acids and general anti-inflammatory properties that this has. So these are data from the ESSENCE trial. So the ESSENCE trial was presented at the liver meeting as well, and this is the end of the phase 3 trial. So this is escalating doses of semaglutide up to 2.4 milligrams versus placebo, and these are the 72-week data, which were the interim analysis pre-planned. The paper was just resubmitted and should be published very soon. But basically, this was a metabolically enriched cohort, as we generally see in this disease. Primary endpoints are MASH resolution without worsening of fibrosis, and fibrosis improvement without worsening of steatohepatitis. And these are the standard regulatory endpoints that we use today for FDA approval. It's important always to look at the baseline characteristics of these studies. This is fairly typical, although generally you see a little bit more female predominance in most studies and a little bit more diabetes enrichment, but over half had diabetes. And fibrosis stage 3, this is something you're going to see in all advanced phase trials. Why? Because stage 3 is closer, of course, to stage 4, and progression from stage 3 to stage 4 is an FDA approvable final outcome that will allow for complete approval of a drug, as opposed to conditional or accelerated approval. So these are the top line results. You can see very significant differences between drug and placebo with respect to MASH resolution in the upper right hand, 63 versus 34%. And in the lower panel, you can see a statistically significant reduction in fibrosis as well. And so this was very important because in the phase 2b trial, there was no statistical significance in fibrosis reduction, and this mostly just speaks to, I think, the numbers of patients involved in this study, much larger trial, obviously, than in the phase 2b trial. So again, gives further confidence that with prolonged therapy, this is 72 weeks, you may start to see a reduction in fibrosis over time. The loss of body weight was expected, and 11% may seem not very high because if you look at the standard obesity trials or even the diabetes trials, this is a bit lower, but this is about in keeping with cardiovascular trials with semaglutide use. Importantly, when you see both MASH resolution and fibrosis improvement, that's, I think, further gives you confidence that a drug's actually doing something. And here again, there is statistical significance, and these were pre-specified analyses. That's why you see a P value there. So other things that give us confidence, I don't think it's very surprising given the histologic findings that we might see a nice reduction in ALT, AST, and GGT, which is what was seen. But then really importantly, because ultimately we want to not be using liver biopsy, so there was a reduction in VCTE of 20%. This is just shy of what we might want to see. So the coefficient of variation of the VCTE is about 30%. So really anything above that should give you high confidence. So this is not quite there, but again, does certainly suggest that there's an improvement. ELF score reduced by 0.6 units, which we think beyond 0.5 units is associated with fibrosis improvement, and PRO-C3, we think that about a 25% reduction. So all of these are in the same direction, and I think that's also important. From a safety perspective, safety perspective, I think the main thing to focus on, I think generally it's a safe drug. The gallbladder-related disorders is something that came out as a difference between treatment and placebo, but again, not terribly surprising. When you lose a lot of weight, you're going to see increased lithogenicity of bile and gallbladder events potentially. So this is important. These are data from Target NASH, which is a real-world evidence cohort in the United States of 4,000 patients here. You can see about 10% or so had MASLD, and you can see that there is a reduction in disease progression and in all-cause mortality in patients who were on GLP-1 use, suggesting that over time we're going to see a reduction in liver-related events, which is actually also demonstrated in another retrospective study as well, but this was presented at AASLD. Moving on to FGF21 analogs, this is, I think, a really exciting target. So FGF21 is a non-mitogenic hormone that is produced by the liver. It has multiple actions. It's got pleiotropic effects, either both direct effects and also indirect effects through increasing adiponectin. But the issue, and this is a hormone that's activated by metabolic stress. So whether it's food intake, alcohol, or other metabolic stresses, this hormone in your body goes up. The problem is it's a very short half-life. So there are actually at least three and more significant development of drugs that are targeting this by prolonging the half-life. And one of those is efruxifermin. And these are data for the Harmony phase 2b trial in non-cirrhotic MASH. You can see that patients were randomized to 2 doses of efruxifermin versus placebo and then had a biopsy at week 24, which was presented previously and had significant results both in fibrosis and in MASH resolution, and then 96 weeks. So one thing I'll tell you about this mechanism is that we worry about the durability of response. So there was a prior compound that had anti-drug antibodies and other mechanisms through which the effectiveness of the drug went down over time. So it was important to see how patients did with 96 weeks of therapy. So importantly, there was maintaining of the MASH resolution, albeit slightly lower numerically, and fibrosis improvement that continued. And this represents patients who both sustained their response and also added response that responded late, so to speak. So I think this was exciting and really important data. So triglycerides also go down with this drug, and insulin resistance also improves. So we are doing a lot of digital pathology these days, looking at compounds, and I think it's particularly useful, not so much in a drug like this that I think very clearly works, but in drugs at earlier stages of development that we want to know whether they're working or not working and to what extent. So this is looking at histoindex, which is a digital pathology methodology. To the left, you can see histology, and to the right, you see staging through Q fibrosis with histoindex. You can see, for example, here with the 28-week data point, you see a higher response rate as measured by digital pathology, and I think that's probably because it's detecting changes a bit earlier. Looking at the 96 weeks, it's picking up already, again, the same response that was previously not picked up. So I think it's a way to detect changes sooner. Looking at the 50 milligrams, you see somewhat similar impacts. Again, you're seeing at the 50 milligram group an earlier demonstration of response that then is probably close to maximal response once you get to the 96-week time point. So What's really important, I think, with NITs, because we, again, do not want to continue to use liver biopsy, is how many of these NITs are what I would say directionally aligned, meaning they're all going in the right direction. That increases your confidence that you're actually seeing a true effect. So these are also data from the same study. You can see that in the placebo group, there were 47% of patients in the placebo group had had neither VCTE improvement or fibrosis improvement histologically or a reduction in ELF. In contrast, looking at the 28 milligram dose, you see that 19% had all three of these aligned, with only 23% having none, and then the 50 milligram group, no patients had no change in any of these, and 42% had all three. So I think this is really important, and I'd like to see more data presented like this because it gives us increased confidence. The other thing that's important to see with this, but with any study, any drug trial, is the dose dependency of the effect. And so again, this also demonstrates that. So this is a trial in cirrhosis. Okay, cirrhosis has been very difficult. As you know, it's a very difficult state to actually treat and reverse. And the point of this study was to see if you could reverse cirrhosis. This was not presented at AASLD, but it was presented in a press release just after in January, because it's very exciting results, so I think you should see it. MASH resolution, very high, even in the context of cirrhosis, but almost 30% of patients had a reversal of cirrhosis in this trial with this drug after 96 weeks, compared to 12% in the placebo group. So this is really, I think, the most exciting treatment effect that I've seen in this space. Liver stiffness also went down by 24% compared to 8%, and ELF also dropped below that 0.5 threshold, which I think is also super important. Efimosfermin is another FGF21 analog, but it lasts longer. It lasts 1 month, so you can just treat once a month with this drug. The other FGF21, which is in advanced development, called pegozafermin, didn't present any data at AASLD, but also has very exciting results published in the New England Journal last year. But anyway, this is efimosfermin, and this study was a shorter study, a 24-week study, and even with biopsy, even after only 24 weeks, you're seeing very significant reduction in steatohepatitis, or resolution, I say, of steatohepatitis, and also improvement in fibrosis. So we look forward to seeing more from this particular drug. So we're going to close, like we started a little bit, with the impact of genetic polymorphisms on this disease. So we're going to look at how we may see changes in response based on polymorphisms in PNPLA3. So these are data from the Maestro-NASH trial, which is the resmetirom study, phase 3 study. And you can see here that PNPLA3, HSD17B13, which is a protective variant, and TM6SF2, which is a deleterious variant like PNPLA3, there was really no significant difference in treatment response with respect to MASH resolution. Looking at the tirzepatide study, so tirzepatide is a GLP-1 GIP agonist, as you know, and you can see here there was a bit of a difference actually with tirzepatide. So the treatment effect for MASH resolution was greater in those with the CC genotype. That's not the at-risk one. So the G allele was an impediment to response, so to speak, but the numbers are really small, so I would just caution that. But there did appear to be an impact. When you look at fibrosis improvement with the resmetirom's data, there's no impact on response by genotype. And this is also true for the tirzepatide groups, as you can see here. So much less of a difference between the carriers and non-carriers. So as far as takeaways, I think we were very excited to see positive interim analysis for semaglutide. This is a phase 3 trial. Hopefully that will lead to FDA approval in the next year or so. Met both regulatory endpoints, which are the ones required by the European Medicines Agency as well. So hopefully that will be approved by the EMA at some point as well. Efruxifermin is the first drug to show fibrosis reduction in cirrhosis in this space. It's very exciting data, and we look forward to the phase 3, which is ongoing right now. With respect to genetic risk alleles, they may have different effects on therapy, and that may be mechanism of action dependent, though I really think we need to see bigger numbers to make any conclusions based on that. As far as the pipeline goes, we didn't really talk about that today, but there are several drugs in development that are quite exciting and are already entering phase C development. So I think in the next couple of years, we're going to see a lot of really exciting data. And I think we've made a lot of progress with respect to non-invasive biomarkers and our ability to be liberated from liver biopsy in the future. So with that, I will close and take questions after. Thank you.
Thank you very much for your great presentation, and you summarized the AASLD debrief last year. We will take the question end of the session. Obesity is a chronic progressive metabolic disease. Based on the WHO database in 2022, one of the 8 persons worldwide are obese. I mean, almost 1 billion people are obese, and 2.5 billion persons are overweight. This is a really important question. And in Turkey, almost more than 40% of the adult individuals are obese. This is a really big problem also, as well as in Turkey. Right now, the relationship between the obesity and muscle D presented by Samit Asrani from Baylor University. Thank you very much for accepting our invitation. Thank you very much.